I'm just like everybody else in the room. I think the most important role that I have is being a mother and a long-term foster care to a sibling group of 4 children. So my research, which I've been asked to share some of today, is all driven by my passion for the children in my life and my desire to help other parents and carers be the best parents and carers that they can for the children that we love and adore. Before we go any further, I too want to acknowledge the traditional custodians, but when I did my Google search, it said, oh no, I got it right. I thought I put someone else on there. I beg your pardon. I didn't get much sleep last night. I too would like to acknowledge the traditional custodians and pay my respects to elders past, present, and those emerging, and extend that respect to anyone who's here today or online with us in Zoom. And hello Zoom, how are you going? Okay, so what I really want to do today is just share a little bit about my research journey. I've been a researcher for the last, I finished my PhD in 2013, so I guess it's 10 years now. It's a decade of research, but was researching for 5 years prior to receiving my PhD. And all of my research, with the exception of one project, focuses on the out-of-home care space and people who are associated with that. So my biggest passion, as was said in my introduction, is infants in out-of-home care, infants and young children. We know that the first 2,000 days of life is extremely important for this age group, and so much happens. We used to argue that it was it nature, was it nurture? We now know that it's an interplay of both, and that if they have the right experiences in those first 2,000 days, we can actually help the hardwiring of their brain. And so that's where parents and carers are so important in the development of these children. We know that infants are inherently vulnerable population. They're completely reliant on the caregivers in their world to help them grow and develop. And we also know that infants and young children under the age of 4 represent the highest proportion of admission to the out-of-home care space. These are the children that are most likely to require long-term care. These are the children who are most likely to be adopted or go into permanent care. They're also more likely to be the subject of allegations and substantiations of neglect and abuse than any other age child. And many infants in out-of-home care have increased incidence of health issues, and that's even if they go into the out-of-home care system at just a couple of days old. There is a misnomer that if a child is removed at birth and placed into care or placed into adoption, that everything's going to be okay. There are things that we have to deal with, and we need to recognize that the trauma that might have occurred during pregnancy, or the generational trauma that mom may have experienced, or the epigenetic changes that occur because of all of that, do have an implication. It's not the end of the story. Those things are all moldable and workable, but we have to make sure that parents and carers have that information and know what to do with it. So I want to tell you a little bit about my research journey over the last 8 years, and I'll make sure I'm keeping on time, so give me a flick because I can go off on a tangent sometimes. My research journey came to me after I started my journey into parenting. So I became a mom in 1992. I immigrated to Australia. Yes, you heard the accent. I am bilingual. I speak Australian and American. It's okay. Immigrated in 1994, had my second child in 95, had my third child in 96, became a registered nurse in 2003, and started my honors degree. Became a authorized foster care to a sibling group of 2 in 2005. That group later became a sibling group of 3, and then later became a sibling group of 4. I started my PhD, was in my PhD when the 4th one turned up, and somehow had a surprise pregnancy in the middle of all of that, which makes me a mother of 8 and now a grandmother of 2. So the things that I share and the research that I do often comes from the experiences that I've had and the conversations I've had with other parents and carers who've had similar experiences. So one of the first things, I am a registered nurse, that's my original training. So one of the first things I did is I wanted to look at how nurses were dealing with infants who had been born prenatally substance exposed. We know that there's a huge problem with methamphetamine here in Australia, much more so than any other country in the world. We are superstars. We like our methamphetamine an awful lot. And we have more and more infants being born exposed to meth as well as other substances. But how are we dealing with those infants? It was my experience that the children who came into my care who were prenatally substance exposed spent significant amount of time in hospital without a primary caregiver at the bedside. I didn't know if this was just my experience or if this was actually what was happening. So we interviewed nurses and midwives and said, hey, what's going on in the hospital? And they said, hey, not a lot. And I'll share some of that research with you. Then we did some research looking at infant feeding, because I came across a court case where a mother who had had her child removed from her shortly after birth had spent 2.5 months expressing breast milk and taking it to the NGO so that the baby could have access to that breast milk, only to later find out that they were throwing it away. This horrified me, so we did some research into what's happening with breastfeeding and out-of-home care. We looked at substance-exposed infants' need for attachment, whether or not that's being prioritized, and we looked at the models of care that we currently have to look after these infants in hospital and how long they last. We did a really interesting study looking at carers' experiences of receiving infants in the out-of-home care system in Australia, and I'll share those details with you. Then we talked about I did a paper looking at the ethical implications related to not having a formal diagnosis for infants who are prenatally substance exposed. And then the last thing I want to share with you today is a survey that we've done that we haven't published yet from carers who are caring for infants who have been prenatally substance exposed. So it's a journey, but you'll see that it all kind of fits together. So when we talk to nurses about their experiences looking after babies in hospital who are prenatally substance exposed, we found some really interesting things. I wasn't surprised by what we found, but other people are, because they don't think about this context. One of the things we were really interested in is how they facilitate attachment. So if a mother gives birth to a premature baby and that baby ends up in the neonatal ICU or in the special care nursery, the nurses work really hard with those mothers to help them be close to their infants. If they're on life support and they're in a humidity crib, it's really hard to cuddle and bond with your baby. So there are a lot of things that are put in place for infants who are born early and who require a lot of intensive medical intervention. The same things don't happen for infants who are born prenatally substance exposed. What we found is the mothers who are substance using are often not at the bedside, and if they are at the bedside, they're not engaging with the infants. One of the reasons they're not engaging is because the substances that they use interfere with their oxytocin, which is our love hormone, and that's the thing that causes women to go through a whole lot of pain and still love the thing that caused them that pain after it arrives. They don't have the same level of oxytocin, so they don't look to bond with the baby the same way as a mother who does have oxytocin on board would. Incidentally, the babies also have depleted oxytocin, so they're not looking to bond. This is something that we don't tell parents and carers, and in fact, a lot of the nurses who work with these babies don't realize this either. But what we found is that there is an emphasis on the child's physical health and well-being and less as it relates to their mental health. And for an infant, mental health is all about attachment. Often the mothers who are using are restricted in their access while they're being assessed by the social service system. And let me just tell you, infants can't have long distance relationships. They have attachment with whoever's there consistently. So if you restrict a mother's access to 2 or 3 times a week, they're not going to be able to bond with that baby. If you don't assign an alternate caregiver during that time, that baby bonds with no one. And then we have the same sort of circumstances as the Romanian orphanages that we know cause brain damage. But we do it here in Australia because we prioritize physical health over mental health. And we find it really, really disturbing. And it was interesting when we asked the nurses about what do you do to facilitate attachment, they immediately thought we were talking about breastfeeding. And I said, no, mental health. We're talking about mental health. What do you do when the mom's not there? And they said, well, we just do the best that we can, which is the last quote that you see there on the screen. So after that, I got my name tag is in my hair. After that, I wrote a paper with a couple of pediatricians from the United States, which really impressed my dad. He said, how'd you meet doctors in America? I said, I'm connected, Dad. And we did a review of the models of care that are currently in place for babies who are born prenatally substance exposed. And these are models of care in the United States, in New Zealand, in Australia, around the globe. And what we found overwhelmingly is that they focus only on what happens in the hospital. They don't talk about follow-up. They don't talk about working with the infants and the families once they go home. And surprise, surprise, they emphasize physical well-being of these infants. So I, of course, used that as an opportunity to put my 2 cents in and said we need to do more. The other thing is they don't look at adoptive parents, carers, or guardians at all. All of the research looks at the infant and the biological family. We know a lot of these infants end up in care, even if only for a temporary period of time, but there's no research that's looking at these infants and their carers. So one of the things that we concluded was, when we're looking at the different sorts of care that they have, there's pharmacological treatment, there's non-pharmacological treatment. A lot of the non-pharmacological treatment doesn't have robust research underneath it. It might be things like swaddling or brown noise or placental sounds to help soothe the baby, things like that. But there's not a lot of research. There's small studies that say, yeah, we think it works, but not really robust. The most robust research they have says that kangaroo care or skin-to-skin contact for these babies is really, really effective, and that rooming in with their moms is really, really effective at shortening the length of stay and the length of medical treatment that these babies require. But none of that research has been done with foster carers or adoptive parents. That research says that it will actually reduce the infant's heart rate, because one of the things that happens during withdrawal is they have a really fast heart rate and they breathe really fast, which is one of the reasons why we monitor them in hospital. And they have really high levels of cortisol, which is our stress hormone, which to an infant, if consistently high, can be neurotoxic, which is why it's such a big deal. The research says that for the mothers and the infants, when it comes to rooming in and kangaroo care, is that it reduces their heart rate, it reduces their rest rate, it reduces their cortisol for both the mother and the infant. Great outcome. But again, these are dyads that are biologically linked, not looking at carers. So I, of course, added the last bit in there that says research investigating scenarios where the infant has been separated from the mother are also warranted, because we know that happens to so many of them. In our infant feeding research, like I said, we wanted to look into this because of what I had found in court records related to a mother who was expressing. But we also wanted to know what carers were doing in terms of how do they select formula, how do they know what to give the baby, who's giving them guidance, and that sort of thing. So we did interviews and surveys with carers across Australia, and we found in general there's a lot of support for breastfeeding, which the midwives I work with were so happy, because they all say breast is best. And I suppose that's what the research says. The research actually indicates that babies who are breastfed have better immunity because they get the mother's immunity. They have less likelihood of developing things like asthma and eczema. Long term, they do better socially. Their neurodevelopment is more in line with typical trajectory, and they tend to perform better at school and things like that. So that's what the breastfeeding research says across the board. But when a child is removed from their mother, there's a disconnection that occurs at that point. So carers largely said that they support breastfeeding. They think it's a good thing for infants in care. And they see it as beneficial for both the infant and for the mom in terms of things like attachment. So it's useful for bonding. That's something only mom can do, right? Because we don't use wet nurses in Australia. And so that's a really beautiful, lovely thing. But there was a caveat there. Many of them were concerned about frequent visits for the infant in order to facilitate breastfeeding. So what if the driver was late picking the infant up? What if the mother was late arriving to the appointment and the baby's left screaming because they're hungry? And then we give them a bottle and then the baby doesn't want to feed and then mom is upset. So there's a lot of logistical issues that occur there. Some infants travel a great distance in order to see their mom, and being removed from the primary caregiver, who is the carer, to facilitate breastfeeding, there's an ethical dilemma there. Charles Zena, who writes a lot about attachment, psychiatrist in the United States, has written a couple of articles about whether or not frequent infant contact is actually developmentally appropriate, because removing them from the primary caregiver in order to have these visits with someone who is a virtual stranger to them could be causing that infant damage. That's a very controversial perspective, but that's something that he writes about. If we're doing that to facilitate breastfeeding, it's probably happening a lot. One of the biggest concerns that we found from our carers was concern that what if the mom is using? What if there are substances in the breast milk? And we talked about breast milk being provided, not only having visits to facilitate feeding, but also having breast milk provided. And if you're handed a bottle of breast milk, express breast milk, you don't know what's in that. That was the concern of carers. What if mom's using? What if I give this bottle to the baby and it makes the baby sick? Who's responsible? That's a really good question. There are no guidelines that I could find in Australia that say who's responsible. Would the mother be responsible? Would the NGO or the government body be responsible, or would the carer be responsible? And so as a consequence, if the mother has gone to the trouble to express and the carer isn't comfortable giving it, it often gets thrown away. There is a lot we could do to remedy this. Unfortunately, we haven't. In the interviews that we did, there was one carer in Western Australia who I interviewed who was really, she was an ardent advocate. I think she was a midwife. And she had a young baby in her care who had been born prenatally substance exposed. He was premature. He was an Aboriginal child. And she had contacted the breast milk bank and requested breast milk for this baby and was told that he wasn't vulnerable enough. So access to breast milk in Australia for these children is really difficult. That's also something that could be easily remedied with a few policy changes. When we looked at carers of infants across Australia, we found some really interesting things. So all of this research has been building to this point because I wanted to be able to capture a picture of what it's really like, because people didn't really understand that it's as simple as I put my hand up, I become a carer, a baby becomes available, someone rocks up to my door with a tin of formula, and if I'm lucky, a nappy bag and a baby. And it's usually a Friday afternoon when it happens. And they go, here you go, good luck. And you don't hear from them for a couple of weeks. And that is a very traumatizing circumstance for some people because that's not what they expected to happen. So we did interviews, we had a survey and we did interviews. We had 232 people respond. Some of them were from Victoria, the most from New South Wales, probably because I was pushing it out on social media in New South Wales, where I live currently. The majority of the carers who responded were women, and the majority were married. Interestingly, 33% had had no biological children of their own. And in the infant feeding study that we did, it was, I think, 26% who had had no biological children of their own. And there is a group of carers who choose to become carers because they want to fulfill a parental role and haven't been able to do that via the traditional means, I suppose. I don't know how else to say it. But it was their opportunity to fulfill a parental role. And what we found in this research was that those who had not had biological children were younger than the average foster care. So average foster cares in Australia for women in particular are 45 to 55. I sit right in that pocket. You can do the math. But these carers were younger. They tended to be 35 to 45. And they were more educated than the average foster care in Australia. So we asked questions like this: how did the infant get to your house? Because again, people don't believe they just rock up and drop them off, you know. Maybe we could get a drive-through going. So the majority of infants were either delivered by the caseworker or collected from the hospital. And for myself, having an infant delivered by a caseworker means you're not getting any sort of direct handover. You know, whether they come from the hospital or they come from another care, you've got someone telling the caseworker something to pass on to you. And as a registered nurse, I know that handover at the end of a shift is one of the things that we've developed tools and skills in order to be able to make sure that all of the information gets passed across, and then it's passed across in an orderly fashion so you don't forget anything. Taking orders from a doctor over the phone, it's the same thing. We have a standardized protocol that we follow to make sure that we don't forget any information. When we receive care of a child, and particularly an infant, there's no form that comes with it that says this is what's happening. There's no standard protocol of what we hand over. It's just whatever information gets passed on. And whether or not that information is correct, you know, you don't know. And you often don't have any way of checking because you don't have contact with whoever had the infant last. So this is something that could also be easily remedied if we just designed something and implemented it. The infants who were coming into care, you'll see the great majority were less than a week old, very, very young infants. And if you look at the next most prominent, being less than a month. So we're talking about really, really young infants, sometimes being handed over to people who have no experience whatsoever looking after an infant. We asked them why the infants went into care. This was really important to me because we have no clear reporting mechanism in Australia that says children go into care because of prenatal substance exposure. In New South Wales, they report it as physical abuse, sexual abuse, or emotional abuse, or neglect. Well, if you have a child that's been prenatally substance exposed, it could be 3 of those 4. So how are they actually categorizing them? So we wanted to capture the proportion that was going into care because of parental substance use. So we had almost 40% of our participants said that that's why the infants were in care. And of that 40%, 98% indicated they thought mom was using during pregnancy. So it wasn't just parental substance use in the home and concern about them being around meth labs or things like that. It was active maternal use. We also asked these carers if they'd received training related to prenatal substance exposure, and only 20% of them had, which is, I think, terrible. Okay, I need to speed up or we're not going to get through everything. We asked things about whether or not they were visited by a community nurse or midwife, whether or not they went to community health nurses. So I was surprised to hear that almost a third were actually visited by a community nurse or midwife. That really surprised me because there's no referral mechanism. In most local health districts, when a woman gives birth, she's referred. And so the community nurse or midwife go out to see her and they do a well baby check. If the baby goes into care, there's no referral mechanism. So for these young infants who actually receive those visits, we need to further explore how they got those visits. A third of the carers reported receiving no information or training related to infant feeding. A quarter said they didn't receive any information related to nutrition. Less than a fifth received information related to immunization. Less than a fifth received information related to bathing, sleeping, settling, or developmental milestones. Really important stuff. And these statistics that I'm giving you, most of these people who did receive the information indicated they went and found it themselves, which is a real concern because Dr. Google is not always right. If they're not going to the right sites, they could be getting the wrong information. So this information was not being freely available to them. Incidentally, those who had not had children prior to becoming a care and assuming care of an infant were more likely to receive information than those who had already had children of their own. This is a concern because there is an assumption that people who have had children of their own already know what they're doing. Well, I can tell you categorically, when I had my first infant come to me from out of home care, it had been over 13 years since I'd given birth. Things change. SIDS guidelines are a really good example. It used to be on the face, then it was on the side with the tri-pillow, now it's on the back. It changes, so we can't just assume that people have kept up with infant standards. Third of the carers reported receiving information related to infant attachment and developmental trauma. And this is really important because infant attachment, of course, is fundamental to their mental health. But when we interviewed them about developmental trauma, they hadn't actually received any information about infant trauma or how to recognize trauma in an infant or how to respond to an infant with trauma. They had received high-level trauma training that usually started talking about toddlerhood and up. And so that's not very helpful if you're looking after an infant. But 41% of the carers in our study received no training at all in relation to infant caregiving, which was really, really shocking. So as a result, we have now designed training that is delivered by myself and a child and family health nurse. The first half of the training focuses on basic infant caregiving. We've got the antenatal babies, we show them how to wrap them, we show them how to pick bottles, we show them where to go to select formula, things like that, all that basic infant caregiving. We demonstrate a dry bath, because there's no bathtub when we demonstrate those things. But then we also address issues like how to prepare a baby to go for contact. What do you do? How do you comfort a baby who's been away from you for 3 or 4 hours? How do you manage to say goodbye if that's what happens because the infant moves on and things like that? And so far we've rolled it out. I think we've given it 6 times in New South Wales so far this year, and it's been really well received. And it's interesting because it's the carers who have had children of their own who appreciate it the most, because it is very, very different when it's someone else's kid initially. This research I thought was really, really important because this paper talks about the importance of actually giving a diagnosis to children who are prenatally substance exposed. There has been a huge public awareness campaign about fetal alcohol spectrum disorder. They're doing a fantastic job getting the information out there. Don't drink when you're pregnant. Don't drink if you're trying to become pregnant, because it has long-lasting implications for that child's health and well-being. We don't have the same thing in place for infants who are prenatally substance exposed to other substances, licit and illicit. And unfortunately, because of that, those children often fall through the cracks. If you get a diagnosis of fetal alcohol spectrum disorder, wherever you are on the spectrum, it's like a golden ticket to the NDIS. If you've been prenatally exposed to something else, it gets you nothing. And in fact, the only two diagnoses that are available are neonatal abstinence syndrome and neonatal opioid withdrawal syndrome. And NAS and NOWS both actually officially refer to opioid exposure and withdrawal. NAS is increasingly being used to refer to any substance, but that's an inappropriate use of it. Both of those diagnoses, if the infant receives it, resolve as soon as withdrawal symptoms are gone. And there is nothing to follow that child and warn the health practitioners and the educators and the parents and the carers that this history is there and that it has implications. And unfortunately, there are a lot of people that don't acknowledge that there are long-term implications of being prenatally substance exposed. So there is a push to create a diagnosis, not because I like to put labels on kids, but because that's how we access the services in this country. But there's a stigma associated with it, so unfortunately, it hasn't happened yet. The research we've done with carers who have been looking after infants and children with a history of prenatal substance exposure are reporting these things to us. So the research, there's no long-term follow-up research for these kids. The largest study in the world following methamphetamine is being run in the United States and New Zealand. Tricia Woods is leading it in New Zealand. It's called the IDEAL study, and they're out of money. They've got lots of data, and they have no money. So they're really struggling to get the research out. And the person who was leading it in the United States has unfortunately passed away. So they haven't assigned a new leader to that study. So that's all kind of frozen. And that's the research we really need because it's methamphetamine. But this is what carers in the US and Australia are saying, because we did both countries. These infants, as they're moving on, they have mobility problems, they have behavioral issues, they have learning difficulties, mental health conditions, cognitive issues, hearing issues, vision issues, and other additional health-related issues. I get an average of 2 emails a week from parents and carers in many Western countries who've heard a radio interview or read a blog or something that I've written, and they contact me and say, can you please tell us what we can do? We don't know what to do. Because the pediatricians and the practitioners out there don't know what to do either, because there isn't enough large-scale research to actually say this is what's happening. These carers are saying only 13% felt that they were being sufficiently supported to care for these children. 100% wanted more services after infancy. Like I said, most of the services focus on that withdrawal period, and then they just kind of ignore what happens after that. 91 felt that it would be persistent through adolescence and childhood, and 94% felt that children's adult life would be impacted. There is so much that's happening in this space with early childhood and with prenatal substance exposure that we could be doing. There's things we could be addressing. And one of the biggest issues is awareness and getting people to understand that there are persistent issues that are happening there. Another one is getting a diagnosis so that we can get people to say, hey, okay, we know something's happening here. Let's work with this family to help get the best outcomes possible. A lot of the symptoms that children with prenatal substance exposure have are similar to trauma symptoms as well. Compromised executive functioning. The dopamine receptors in our brain, which is where most addictive substances work, are primarily in the prefrontal cortex. The prefrontal cortex of our brain is also where executive function occurs primarily, and that's impulse control, that's short-term working memory, and that's mental flexibility. The ability to pay attention, the ability to adapt to change and not have to adhere to routine, and the ability to remember more than one instruction at a time. Those are all essential skills to navigate the world, but we often struggle kids who struggle with executive function end up in trouble at school, they end up in trouble with the police, they end up being labeled defiant and not following instructions. And often it's because they have dysfunctional executive function. If we looked back and saw, oh, prenatal substance exposure, or oh, trauma, then we would know that they're not just behaviors, they're neurologic symptoms of a deficit. If you have a child who has a neurologic disability because he's been in a car accident and he had a neck injury that's rendered him unable to walk, that's a neurologic disability. And what happens in society is we see that disability and we cater for that disability. We rally around that child and we raise money and we get wheelchairs and we put in lifts and we put in ramps at school because we want to help that child. But if your child has an invisible neurologic disability, like compromised executive function, and the symptoms that manifest are not following instructions, not remembering what they're supposed to do, not being able to control their impulses, then we label that bad behavior and we punish them. So the community awareness really, really needs to change so that we can better support these children and the parents who are caring for them. I can't tell you how many times I'm on speed dial at my kids' school. All the principals know me by name. All the office ladies know when I ring, one of the kids are in trouble again. I'm very pleased to say that out of my 4 long-term kids, the eldest is now 20 and has a job, finished his traineeship. He's doing fantastic. He's still living at home, of course, because children don't leave until they're like 40 nowadays. His sisters managed to finish school as well. Their next brother is in year 12. God help me, we'll make it through the last 9 months of that. And then there's one more to get through school. It's been a challenge, but they can do it. There are ways to help support these kids to get to where they need to. We have to learn as their parents and carers to be their prefrontal cortex until they can eventually catch up with everybody else. So some of the conclusions that I have come to based on this research that I have been conducting and on the research that's out there, and I've got many other studies. We're doing lots of stuff with carers and lots of stuff with adoptive families too, but this is just kind of a snapshot because they said 20 minutes and I think I've already gone over. Sorry. Treatment options. Most of the treatment that these kids would receive, they would only receive if they remained with their biological families. So if they go into care, if they go into permanent care, foster care, if they're adopted, those services need to be available to those children in those contexts. There are currently no clear referral pathways. I don't care which state or territory you're in, no clear referral pathways. You have to be a really ardent advocate and very proactive in order to get those services. There's minimal recognition of the enduring impact of prenatal substance exposure. A diagnosis is needed there to support these children and their families. Really super important. My research has found that carers are not well supported to provide care to infants. Training related to attachment and developmental trauma is insufficient and it often doesn't focus on infancy. Training related to basic infant care is minimal. There's nothing there. As far as I know, I'm the only one doing it. There appears to be an assumption that carers with biological children don't need support. I challenge that. I think they do. And infants and carers in out-of-home care don't routinely receive those equitable services like nurse home visiting. I have a dream, and I've been working on it for 10 years. As soon as someone funds me, if we get all that child support money we were talking about, I want to develop a nurse home visiting program specifically for kids who go into care, so that the nurses can be working with the carers while they have that infant, helping them to recognize trauma, helping them to support attachment, helping them to reach developmental milestones in a typical fashion, and referring them to services when they don't, because that's what nurse home visitors do. If that child's reunited with the family, the nurse follows to support the mom, because there's no point doing all of that work to only send the baby back and not continue to provide that support. Currently, what happens when we send them back is we monitor and surveil. We need to mentor and support. And I think having a nurse home visiting program would do that. That's my big dream. So if anyone comes into money, let me know and we'll make that happen. And these are my contact details. I run a Facebook site, which I post information about the research I'm doing and the research other people are doing that will hopefully be helpful for you. But I've gone over time, I'm so sorry.